we are going to listen Dr. Pablo Duran. Dr. Pablo Duran is a medical doctor and PhD from University of Buenos Aires, MPH from University of El Salvador in Buenos Aires in Argentina, and specialized in pediatrics at the Children's Hospital Pedro de Elizalde, fellow in international nutrition and nutritional epidemiology in Cornell University in Ithaca, New York, USA, master in scientific, medical, and environmental journalism and communication from the University Pompeu Fabra from Barcelona, master in epistemology and history of science of Universidad de 3 de Febrero, Argentina. Currently is a regional advisor on perinatal health at the Latin American Center for Perinatology and since 2010 at the Pan American Health Organization, World Health Organization. Associated Professor, School of Public Health, University de Buenos Aires, Argentina. And visiting professor and advisor of students from Columbia University, Cornell University, George Washington University, Johns Hopkins University, École des Hautes Études en Santé Publique. With more than 25 years of clinical experience as a researcher and expert in epidemiology, monitoring and evaluation of population-based policy and intervention in maternal and child health. He has received 9 awards for scientific work related to child nutrition, 4 fellowships in Argentina and abroad, and has published more than 75 papers in peer-reviewed journals, and is the author of more than 15 books or collaboration in books and technical publication.
Thank you. Thank you very much. Thank you, Natalie, for the introduction, and thank you to the organizing committee for the invitation. And I would also like to thank the authorities and staff from the Hospital Universitario 12 de Octubre for the hospitality and all of you for your attention. I'm going to address the topic of strategy for KMC implementation in Latin America and the Caribbean. And I have to start by framing that this presentation will cover the activity and the interventions that we from PAHO, WHO, and the Latin American Center perform at the region. And this is based on our mission, which is to be the secretariat, the technical secretariat of the Ministry of Health at country level, and to work and to provide technical cooperation for rising, consolidating, implementing the evidence-based interventions, assessing, evaluating, and promoting policies to address the goals established. And for that, we need to frame the current situation in terms of preterm birth in the context of the Americas, where around 15 million births are reported every year, and from them 1.2 million are born prematurely with the consequences that you know. But I would only briefly mention the 3 main challenges in terms of the burden of mortality related to newborn and preterm birth in the region. One is, I'm sorry, but I cannot use the pointer, but one of its challenges is the still high burden of mortality and the high contribution of the neonatal component within the under 5 and infant mortality. The second one is the low speed of reduction in neonatal mortality. And the third one is the huge inequities and inequalities between countries and within countries. And even when the regional neonatal mortality rate is below the goal established by the SDGs and the Global Strategy of Women, Children, and Adolescent Health by 2030, which is a number of 7 per 1,000 neonatal mortality rate, and almost 8 of stillbirth. This is still a high number for our region. But it's not only about the burden of mortality, but also the burden of morbidity and disability that is a main problem in the region. You can see that within the 10 conditions that mainly contribute to the burden of disability, neonatal conditions and birth defects account for more than 50 million years of DALYs, disability adjusted years of life. And preterm birth account for more than 5 million years in the region. So this is an important burden, and within these conditions, the number of deaths that can be averted. This is a study that we performed in 2014 in order to estimate the potential impact of 3 levels of scale-up interventions in the reduction on neonatal stillbirth and under 5 mortality. And you can see that more than or around 50,000 deaths can be prevented implementing key and basic interventions within KMC is included. And if we disaggregate these deaths that can be prevented, we can see that those related to preterm birth, those related to sepsis, and those related to asphyxia account for almost these 40,000 deaths that can be prevented. So the situation is that, and based on that, there are some global and regional frameworks that guide country states or member states and countries in the region in order to address the goals expected. In 2008, the region and the member states approved this regional strategy and plan of action for neonatal health within the continuum of care for maternal, newborn, and child care. And this is really a very early comprehensive approach and political framework that countries were working, and up to 2015, when this plan was evaluated, the goals were reached, the goals expected were reached, but also the challenges remain. And the main conclusion was to continue implementing what every Newborn Action Plan, what was approved in 2014, and then the Global Strategy for Women, Children, and Adolescents on 2016, identified as the main objectives of Survive, Thrive, and Transform. And within addressing the specificities of the region, a regional plan of action for women's, children, and adolescent health were approved on 2018. So we have a global and regional frameworks that promote countries to implement and to address these challenges related to newborn health and prematurity and its consequences. But once made this introduction, I would like to focus on this idea of co-production. Professor Sheila Hasanoff, who is professor of science and technology studies at Harvard Kennedy School, considers that natural and social order are co-produced. And this means that within this concept, the simultaneous process through which modern societies, from their epistemic and normative understanding of the world, this works through the interaction of artifacts and knowledge, and making representations, identities, discourses, and institutions. And in fact, this is what we are discussing, how to move from the scientific, from the artifact, from the technology, to making it real at the society. And for that, we need to consider the interrelationship between the evidence and the guidelines, but within an institutional culture that adopts and make it real, this normative and this evidence and these guidelines. But also we need human resources, we need surveillance systems that allow for monitoring and evaluating the movement and the results. We need physical resources, and we have been discussing about the need for all these components, we need information and education and communication technologies to reach to those who can make the change. And obviously, we need at country level policies, normative, legislative, and regulatory frameworks that make it possible also, with obviously the community participation. And with each of these components are essential for addressing the goals that we are looking for. And in terms of newborn quality of care, the WHO framework or standards for improving quality of care consider these two pillars of provision of care based on evidence, but also the experience of care. And this is why we are working not only on the evidence, which is, as we were talking, available on 2020, we presented based on the process of evidence-based review and consolidation, these recommendations and guidelines on follow-up to newborns at risk, trying to provide a general framework based on evidence for country to implement follow-up to preterm, small, and sick newborns. And within this guideline, the two first questions that were addressed were including in the recommendations at the time of discharging high-risk neonates from the neonatal intensive care unit, the kangaroo care, and also as the information to be provided to parents at the time of discharge, how to manage KMC. But this is the evidence that countries need to adapt and adopt in order to make it real. And now we have the updated WHO guidelines that also we discussed today about implementing KMC. So the evidence is real, is there, but based on what I mentioned before, we need to make it real, and we need to link this evidence to training and building capacity at the health facilities. And for that reason, we are working, and I have to recognize Dr. Natalie Charpak and the colleagues from the Fundación Canguro from Colombia, that we are working together in order to strengthen human resources and to provide training by strengthening the implementation of KMC. During this year, we have coordinated, and the foundation provided training in El Salvador and Guatemala through a training of trainers approach, and another additional countries are expected to be implemented during the next year. And we are also working on the design and implementation national and institutional KMC programs as a result of this training. And online introductory course on KMC, also with Fundación Canguro, is being developed in order to have this introductory module in order to facilitate the training process. So we have the evidence, we are working on training, and as Dr. Charpak mentioned regarding Colombia, and along with the foundation, we are working on mapping the resources available for KMC in the region, identifying current implementation in Latin America and Caribbean countries. This is also an implementation ongoing process. The preliminary results with few responses identified that most of the KMC programs are within the public sector, within institutions of level 3 and 4, with NICUs, with high proportion of open services. 3/4 provide KMC in service, and 1/4 of the responded also after discharge, but with high variability in terms of resources, coverage, and results. So having this information, having this mapping will also be possible from the international, from the regional perspective to contribute at country level to reinforce and strengthen the implementing KMC. I also mentioned that information, education, and communication technologies are essential, and this is why we have also developed and launched last March 2022. This is a mobile app, free, available, downloaded from App Store or Google Play, that it's available in the 4 official languages in the region: English, Spanish, Portuguese, and French. And this app provides evidence-based information. It comes from WHO, PAHO, technical documents and materials on specific topics on newborn health, nutrition, KMC, immunizations, etc. So you can see that you can select the language, you can select the profile, because the information is adapted for families or for healthcare providers. So you can select the profile of the user, and also a search engine that can help on identify specific topics. But I have also mentioned the importance of family and parents' participation, and this is why we also started 2 years ago. We started the process by discussing with our friend and colleague Fabiana Bacchini from Canada, from the Canadian Premature Baby Foundation. And from this initial kickoff, we started trying to identify which are the group of parents, the group of families working at country level in the region of the Americas, in Latin America and the Caribbean. We could identify 21 groups or networks in 15 countries in the region, and based on we are meeting every 2 to 3 times a year, we thought on preparing a material that will help other families, other groups in those countries or cities where it's not available, to start the process of establishing group of parents. And this is why right now we are performing a semi-structured approach, a qualitative approach, in order to learn from them about the constitution process, the conformation of the groups, the linkage with the authorities and professional associations and with other actors. And this is the mapping with the yellow circles, which are the help us on identifying which is the network of relationships that the group established in order to also contribute and facilitate the process of interlink and promoting this way of working in other countries. And this is why the outcome of this process expected is to have a technical document guiding or helping to constitute other groups, but not set by PAHO, but set by the group of parents that are working on that, and a communication material. Surveillance, monitoring, and evaluation is another component that we are working on. The perinatal information system is a tool that started 30 years ago. It's a clinical or a set of clinical records. Started as paper-based, then computer-based, and now is online-based tool for recording data from reproductive health, prenatal, delivery, newborn at the NICU, and specific conditions that allows not only for recording the yellow circles identify risk conditions, so at providing clinical care, the professional can identify conditions that may identify a risk condition in the mother or in the newborn. There are specific modules for birth defects, for COVID, and these also allowed us to establish a technical working group for the review. We periodically review the content of this information system, and we established we decide within the group to establish a regional network for perinatal surveillance, working between 2022 and 2023, with the inclusion within other topics of a specific module on KMC during the stay in the NICU and at the time of discharge. So this will allow also to include specific one-click indicators that can bring in a quick manner the consolidated information for the managers at the health facility in order to take this decision based on that. perhaps you cannot see the screen. Well, it's quite big, but there are a set of 4 group of indicators on neonatal quality reports: perinatal reports, quality of care, conditions at discharge, and a module for analysis of inequities. So the system also provides for key indicators as low birth weight, preterm gestational age, immediate breastfeeding or immediate skin-to-skin contact, the gap or the differences between the relative and the absolute gap in terms of measure inequities by maternal education, maternal age, and place of residence. So not only provides resume indicators, but also allows to measure inequities not only in outcomes, but also in interventions. Here we can see, for example, the report, the automatic report, for example, here presenting conditions at discharge with feeding at discharge as one of the key indicators. So as I said at the beginning, and I'm moving to the end of the presentation, I'm going to share briefly another new material or strategy that we launched last February. This policy brief resumes 10 key priority policy or strategies that will contribute on addressing the newborn outcomes. Along with these key policies, a tool for assessing the present situation at country level and to establish a roadmap to reduce the gap between the current situation and the expected key interventions that are promoted to be implemented is provided to countries in order to move on addressing these key 10 policies. I'm going to go rapid through them: the universal health coverage, the preconception care, the care during pregnancy and labor, the essential newborn care for healthy newborns, but I want to look specifically to transforming care for sick and small newborns, and I lost the red line showing that KMC is one of the interventions recommended to be implemented at the national level within the national policies. So these 10 policies provide the policy tip, the resources available, and the description of how to introduce and what kind of strategy to be introduced in the national policies. Early initiation of breastfeeding, nurturing care framework and families and parents' participation, newborn health in humanitarian situations, healthcare workforce for newborn health, and multi-sectorial approach and civil society engagement complete the 10 policies. So we are working now with countries to establish the present current situation and the roadmap to move from the situation that each country is now to the implementation of these key interventions. And finally, the interagency approach is another strategy that we are working on. The Newborn Alliance is an interagency mechanism working at the regional level. It started on 2005, and now we are still working with UN agencies, multilateral organizations and agencies, civil society, scientific and professional associations, Fundación Canguro, and other civil society organizations. And the aim of the Alliance is to promote newborn health within the continuum of reproductive, maternal, and child health. And one of the main strategies is to promote establishing at country level national alliances, which with the leadership of the national authorities and working together with these other actors professional associations, civil society, UN agencies, and other agencies work on accomplishing the expected results. There are successful experiences in Dominican Republic, Bolivia, Paraguay, El Salvador, and we're working also to establishing these interagency and intersectoral mechanisms. So, as I said at the beginning, and I think this is my last slide, making representations, identities, discourses, and institutions needs for strengthening the availability of evidence, the dissemination, and the adoption and adaptation at country level, building capacity, promoting institutional culture, quality and experience of care, but also promoting training and establishing mechanisms. This figure shows that the Instituto Fernando Filgueira from Brazil, who coordinates a national but Latin America networks of human milk banks, is since last year a collaborating center of WHO and PAHO, and this is another technology that we are working with in order to strengthen, implement and strengthen human milk banks in the region at country level. Training, information, education and communication, community and family participation, surveillance and information system, and interagency and multi-sectoral approach is the set of strategies and actions that are in place at this moment in the region, and we from PAHO and WHO are working on that regard. Thank you.